Good morning, everyone. My name is Dr. Mazen Hanna, and I'm the co-director of the Amyloidosis Center here at the Cleveland Clinic. Welcome this morning to our tall rounds titled Treatment of Cardiac Amyloidosis. For those of you who joined us in the fall, we had a previous tall rounds on the diagnosis of cardiac amyloidosis, and then later in the spring, we're going to have a third one in this series, really how to follow patients over time. So without further ado, we're going to start with a case. Dr. Ariane Agdamag, who's part of our heart failure section.
Good morning. I will be presenting a case of biopsy-proven ATTR and AL cardiac amyloid. This is a case of a 51-year-old Caucasian male who initially presented to our clinic with exertional dyspnea. His past medical history was significant for carpal tunnel syndrome, spinal stenosis, bicep tendon rupture, and coronary artery disease. Pertinent in his physical exam included periorbital purple discoloration as well as trace lower extremity edema. Initial workup for his dyspnea on exertion included a transthoracic echocardiogram, which showed severe concentric LVH with interventricular septal thickness of 1.92 cm and posterior wall thickness of 1.9 cm with concern for infiltrative disease. With this, an amyloid evaluation was started. His laboratory tests were significant for an elevated troponin, NT-proBNP, lambda light chain proteinuria, and very low kappa lambda ratio. His EKG showed normal sinus rhythm, low voltage EKG in the left anterior fascicular block. Imaging testing included a PYP scan which showed a visual score grade of 0 with no uptake. His cardiac MRI showed evidence of diffuse abnormal patchy mid-wall left ventricular left late gadolinium enhancement, as well as elevated extracellular volume. His bone marrow biopsy showed no evidence of amyloid deposition. Fluorescence in situ his hybridization was normal. Given these above findings, he was recommended to undergo endomyocardial biopsy for further evaluation. His endomyocardial biopsy was significant for amyloid deposits. This was confirmed on both immunohistochemistry and as well as typing with mass spectrometry, which showed lambda immunoglobulin light chains as well as transthyretin. With this, he underwent genetic testing, which was negative, indicating wild-type ATTR amyloidosis. He was eventually started on daratumumab plus Cyborg regimen with noted good response. He was eventually transitioned to a single-agent daratumumab and was started on tafamidis. He has been following on outpatient basis and has been doing well, tolerating all his medications. This rare case of biopsy-proven AL and ATTR amyloidosis highlights the importance of a thorough investigation as well as a stepwise treatment.
Management of cardiac amyloidosis. There are several kinds of amyloidosis, and the two main types that we're looking into are the AL due to a bone marrow disorder, and the ATTR due to misfolded proteins from the liver due to acquired status called wild type or a genetic mutation called as the hereditary type. Subsequently, either of these deposit in the heart. When the biopsy is done or a tissue sample is analyzed, the pathology shows diffuse involvement of multiple structures, and as a result, you have altered mechanics and heart failure. This is a pictorial representation of an epidemiological view of cardiac amyloidosis. The tip of the iceberg represents clinical stage C and D heart failure. Below the waterline, you see the obvious arrhythmias and valvular heart disease. However, in most instances, this is an unidentified cardiac amyloidosis, and at stage A, you see the extracardiac amyloid deposits. This is a cardiac amyloid spectrum from left to right. The image on the left side simulates the ischemic cascade, and you see that there is orthopedic manifestations. Then you see more of imaging biomarkers. And the images on the right portray diastolic dysfunction due to increased wall thickness and altered tissue Dopplers. And intertwined with these findings are your atrial arrhythmias or arrhythmias in general, and eventually having systolic dysfunction and cardiogenic shock. Management of cardiac amyloid eventually now has twofold mechanisms of treatment. On the right side are the disease-modifying targeted therapies that my colleagues are going to go in detail with more detailed data. And this has evolved and changed the landscape in the last decade with clinical trials. On the left side is a supportive care, which I'm going to go through. This is based predominantly on consensus and specialty guidelines. And the outcomes of most of these data are targeted therapeutics interventions that have been done after that. Management of cardiac amyloid will focus on the top two aspects of supportive care based on these references that we have. Atrial arrhythmias are the predominant finding that we see, and then we see heart blocks, ventricular arrhythmias, and device management. Most importantly, anticoagulation is recommended regardless of the CHA2DS2-VAS score. Incidence of thrombus is seen in multiple areas of the myocardium. And in specific, you do see left atrial mechanics that are altered and can predict thrombotic events. Rhythm control is relatively tolerated, and we'll discuss in the next slide as to why rate control drugs are not well tolerated. And catheter ablation is successful with less recurrence rate over the year in patients with early stages of the disease. And device management follows societal guidelines. These patients do receive appropriate ICD shocks. However, there has not been survival benefit, partly because a host of sudden cardiac death in these patients are related to pump failure, electromechanical dissociation and PEA, and higher defibrillation threshold likely related to amyloid deposition in the myocardium. An ambulatory EKG and electrophysiological study can be done on a case-by-case basis on a consultation. Supportive care for cardiac amyloid in the era of precision medicine and machine learning. Volume management is the mainstay of treatment with a narrow margin of tolerability using MRA, SGLT2, and diuretics. GDMT is poorly tolerated. As you know, most of these patients have restrictive cardiomyopathy, and the heart rate is compensatory, and the fixed volume depends on that compensatory heart rate to produce the cardiac output. So when you suppress these patients' heart rate, they do develop decompensated heart failure. Note on digoxin, our own institution has a database of these patients. It can be used, must be used with caution, with close monitoring, especially in elderly patients, patients with renal dysfunction, and those with concomitant amiodarone use. Autonomic dysfunction and hypotension is a well-known finding as well, as these patients are known to have difficulty in regulating the autonomic nervous system. And TAVR outcomes are better compared to SAVR or medical therapy in the aortic stenosis and amyloid cohort. Ultimately, a multidisciplinary team approach is required for patients with structural surgical interventions and consideration for clinical trials. That brings us to stage D heart failure, where we assess the options on a multidisciplinary team basis. Heart transplantation has been considered, mechanical circulatory support has been considered as well. I believe that the newer drugs are going to change the landscape of these advanced therapies as well. Heart transplant done in our centers are depicted here. And some of the most compelling contraindications is refractory neuropathy or uncontrolled disease, multi-organ involvement, and malnutrition associated with poor outcomes. Mechanical circulatory support is limited by the small LV cavity size, biventricular involvement, and tolerability to anticoagulation. And that brings us to palliative medicine that could be delinked from the prognosis and focused on quality of care and lifestyle to prevent symptomatic hypotension. In addition to compression stockings, most of these drugs can be tailored to patients' individual needs, although precautions and adverse effects to be of note. That brings us to the summary slide of supportive care of cardiac amyloidosis. We reviewed management of heart failure, where GDMT is less tolerated and there is a narrow window of euvolemia. And arrhythmias, in general, follow societal guidelines. And of note, anticoagulation is recommended in these patients due to high thrombotic risk. And I will pass it on to my colleagues. Thank you.
So good morning. I'm going to be talking again about treatment and focusing on stabilizer therapy. So I'm going to briefly review the mechanism of amyloid protein development, review pathways for treatment, and an explosion in the timeline of drugs in development currently, and then specifically discuss the ATTR trial, which examined tafamidis, and the ATTRibute-CM trial recently published, which looked at acoramidis. So if we step back and look at the pathobiology of transthyretin cardiac amyloid, it begins in the liver when the transthyretin protein is produced by hepatocytes, and that usually forms two dimers into a tetramer, which hopefully is stabilized. But with aging and sometimes with the genetic variant, that tetramer can disassociate into folded dimers. Those folded dimers, which are unstable, can form amyloid fibrils. And those amyloid fibrils can then deposit in the heart and the peripheral nerves, causing, obviously, the pathology of the disease. So what are our TTR targets of therapy? So it can begin in actually the protein synthesis level at the mRNA silencing, as well as gene editing coming down the line. We can focus on stabilizing the tetramer, which actually mimics the thyroxine binding into the tetramer and stabilizes it in that tetramer form and prevents the breakdown into the further dimers and the misfolding. And then excitingly, which is brand new, is the removal of fibrils using antibodies specific to these fibrils. And just to note, the only approved therapy so far for cardiac amyloid is tafamidis, FDA approved in 2019. So if you think about diagnosing and treating cardiac amyloid up until 2019, really this was somewhat of an academic exercise focused on volume optimization and potentially the diagnosis, but no available targeted treatment. But if we look now at the explosion of clinical trials in RNA silencing, stabilization therapy, and then monoclonal antibodies to come, this is truly an exciting field to be a part of in current state. So first I'll start with the ATTR trial. This study looked at 441 patients and randomized in a 2-1-2 fashion to tafamidis high dose, tafamidis low dose, and placebo. There was stratification for genotype, including wild type and variant, and disease severity, and examined a hierarchical endpoint of all-cause mortality and CV-related hospitalization. This study was published in the New England Journal in 2018. And as you can see, there's a survival benefit to pooled tafamidis treatment, which included both the high and low dose treatment arms. And you can see that you need to treat for every 7.5 patients treated in the trial, there was a survival benefit. But similarly, if you look at functional endpoints like 6-minute walk or quality of life like KCCQ, tafamidis treatment abated the decline in both of these measures. It's important to note that patients didn't improve, and it's important to set those expectations when you see these patients, that there isn't necessarily an improvement in quality of life or functional capacity, but the decline that we typically see in the natural history of the disease is abated. And so who do we select tafamidis to give to? What is our patient selection process? And this is something that Dr. Hanna taught me in my training, which is it's not necessarily for everybody, but we give it to both wild type and hereditary. We give it to NYHA 1 through 3, those with clinical heart failure, which actually can be an issue in those we're detecting very early due to variant, or some of the early screening programs we do through the carpal tunnel is sometimes they don't have clinical heart failure, so getting them approval can be challenging. But you do set the expectations with your patients that, again, they may not see, there's things we can do to volume optimize or provide GDMT, but they may not necessarily see a reversal in their disease process, but that hopefully we halt the progression. We tend not to give it to NYHA 4. We work them up for advanced therapies. And it's all case by case. And the other red flags would be advanced renal disease and very high NT-proBNP despite volume optimization. The elephant in the room with these drugs is the cost. They often cost $225,000 a year. But thankfully, through efforts here at Cleveland Clinic and our specialty pharmacy that help us with prior authorization and payment assistance programs, the out-of-pocket expense to the patient is often quite reasonable given their help and our efforts. Next, I'll move to acoramidis, which is the newest TTR stabilizer. This stabilizer has a theoretical benefit compared to tafamidis with regards to the fact that it binds both the lysine and the serine residues within the tetramer. The ATTRibute-CM study looked at 632 patients in a phase 3 study. And again, to talk about the increased TTR stabilization, you can see that in vitro, acoramidis has near 100% stabilization of TTR, and that in vivo, in actual patients, there's a rapid durable increase in serum TTR levels in acoramidis compared to high and low dose tafamidis. But what this increased stabilization has on clinical outcomes, we don't understand yet. So the ATTRibute-CM study randomized patients to acoramidis or placebo, very similar inclusion criteria to the ATTRACT study. This was recently published in 2024, just this month, in the New England Journal of Medicine. This study examined a hierarchical endpoint of all-cause mortality, CV hospitalization, change in 6-minute walk, and NT-proBNP. And the win ratio was significantly positive, with a marked reduction in CV hospitalization. There was no difference in all-cause mortality, and we'll talk a little bit about that. I think this is a very nice display of actually temporal changes in our identification and treatment of cardiac amyloidosis. So if you look at the ATTRibute cardiomyopathy placebo arm, there's actually better survival than in the tafamidis treatment arm. And if you look at the median NT-proBNP and the baseline characteristics of the two trials, you'll see that in ATTRibute-CM, they're about 1,000, it's about 1,000 lower. So we're actually identifying patients in earlier NAC stages as time goes on, which is good news, but I think explains part of the reason why we didn't see a survival difference in ATTRibute-CM, but we did in ATTRACT. And then just one last note here is that we do think that the benefit is for earlier patients. So if you look at the subgroup analysis here, NYHA class 1 and 2 has significantly more benefit than those who are NYHA 3. So again, earlier diagnosis is key. So to summarize, tafamidis and acoramidis are two effective transthyretin stabilizers. Acoramidis will be applying for FDA approval soon. Earlier diagnosis is better in treatment. Access and pricing remains a challenge. And I don't think we'll ever know how these stabilizers perform head-to-head, but they both seem to be effective. Thank you.
Changing gear to the next target that we've been studying and that we've been using, we'll go to the silencer therapies. And so this slide is something that we use very often, and it's very helpful to kind of guide yourself to see what the targets that we have currently for TTR amyloidosis. Like Trey talked about the stabilizers. We're going to talk about next about these silencers, which basically block the protein synthesis. And we have several agents in that group. We have patisiran, inotersen, vutrisiran, eplontersen, and lastly, one that's hopefully coming in the future. It's the NTLA 2001, which is a CRISPR-Cas9 technology that we're trying to implement in patients with TTR amyloid. And so when we're talking about reducing the hepatocyte TTR production by the liver, we can divide that into basically two areas where we can target. The gene silencing therapy, which is why they have that name, silencers. We're basically blocking the translation of the mRNA at the mRNA level. And we use two types of different ways of doing that. The small interfering RNAs and the antisense oligonucleotides. The one thing with that you do need repeated dosing intervals. So it's, for example, patisiran, first of all, it's IV, it's every 3 weeks. Vutrisiran and levetiracetam, it's sub-Q, but the frequency, it's a little bit different. One is every 3 months and the other one is every 1 month. And then on the other sides, we have the gene editing therapy, which is something very promising and that we're very excited about, which is selectively removing a segment of the DNA, which is at CRISPR-Cas9. And the good thing about this, we're very hopeful, is that this is just a one and done. You give one IV infusion and that's about it. And we'll talk about a little bit more about that later on. So when first talking about the gene silencing, basically blocking that translation of the TTR mRNA. So on the left side, you see, they have the DNA, you get the transcription, you get the mRNA, and usually you pass on to translation, where at the ribosome level, you get the help to get the polypeptides, proteins, etc. So the goal of the silencers is, by different techniques, trying to block the protein expression. And so the first one, which is the siRNA, which is the short interference RNAs that are utilized, they basically, what they do is they look for complementary messenger RNA, the TTR gene, and they basically get this RISC complex where it helps bind that siRNA to that complex and the complementary messenger RNA, and then help cleavage that section that we want to eliminate so we can degrade it, and ultimately there's no protein expression. There we have patisiran, and then we have vutrisiran as well. When we talk about the antisense oligonucleotides, there also, same thing. It looks for the complementary messenger RNA, and the idea is to try to block the when it attaches to the ribosome, or get the ribonuclease H1 to basically just make them nucleosides from that oligonucleotide, and ultimately also causing no protein expression. So this has been studied already in hereditary ATTR, but polyneuropathy, and has been proven to be effective, and improves quality of life, improves all the scores in the neurology world for these patients. So this is something that's already been used. So first one was patisiran, and inotersen has also been approved, and lastly we had last year the vutrisiran, which is something that we've been using more frequently because of the frequency of the dosing. It's every 3 months instead of having to come for an IV infusion every 3 weeks or a sub-Q infusion every week. So now we have these 3 agents that are approved for hereditary transthyretin amyloidosis with polyneuropathy, started in 2018, and last year 2022, which was the last one that was approved, which is vutrisiran. Just so you guys know how effective this is, the Apollo 8 with the polyneuropathy, when they started treatment, if you compare placebo to the patisiran group, you see how the transthyretin protein significantly decreases in the serum. And this is something that you could technically test just on regular labs by looking at the prealbumin to see if this is working. When it comes now to ATTR cardiomyopathy, which is what we're talking today, we have these 3 trials: Apollo B, Helios B, and the CardioTransform. Like I mentioned, different ways of accomplishing the same thing, basically in the CardioTransform one, that are looking at the patisiran versus placebo, vutrisiran versus placebo, and hypertension versus placebo. The trials have different number of patients that are recruiting, CardioTransform being the most robust. The dosing and the frequency and the way that it's administered is a little bit different in each one, like it's mentioned there. And in terms of the duration, it's mainly 36 months, but I will mention that Apollo B did get the first 12 months in. That's what they initially seeked to look at, but they extended it with an open label program to 36 months. So looking at the Apollo B, so we do have some data now. First, they looked at the primary endpoint was looking at the difference in the 6-minute walk test between placebo and patisiran, and there was only a modest difference, about 15 meters, between the placebo and the patisiran group. They also looked at multiple secondary endpoints. The only one that was statistically significant was this KCCQ score. And if you remember Trey's slide, the difference is very modest here. Over there was much, much bigger when it came to making a change in the KCCQ score, only 3.7 points. Something that was interesting in the trial was that they did look at the NT-proBNP, placebo versus patisiran, and there was a signal that there was a benefit in terms of lowering the NT-proBNP. When you look at the patisiran group, it was a change from like 2,000 to 2,200. So it was still modest, but it's promising that we do have that hope that it at least is improving with NT-proBNP, and maybe with a longer follow-up, we'll be able to see more change. So what do these results really mean? So first, the 6-minute walk and KCCQ score, just modest results. It was only a 12-month report of the placebo versus patisiran, so that's something to take into account. The NT-proBNP and the 6-minute walk targets were a little bit different than ATTR. Something to also mention is about 25% of the patients were on tafamidis as well, in addition to the silencers. Based on this trial that was published already in the New England Journal, it was not FDA approved. They did not think that there was enough evidence that this was beneficial. So changing gears to the other way that we can potentially change that gene expression or the liver of producing the ATTR protein, we have the CRISPR-Cas9. This is very promising because it's just one injection that the patient has. There's this phase 1 trial where they looked at in patients with hereditary ATTR amyloid polyneuropathy. The drug is NTLA-2001. They only looked at 6 patients there, age 46 to 64, 4 men, 2 women. And basically, there were very small amount of side effects, so proven to be safe. So then they moved ahead with a phase 2 trial. Just to get a brief overview of what the NTLA-2001, what the CRISPR-Cas9 in amyloid is. So basically this NTLA-2001 is a complex that's formed by this lipid nanoparticle that has the TTR-specific sgRNA, the single guide RNA that has the complementary sequence of the TTR gene, and it also has that Cas9 messenger RNA. This, once injected, it gets ApoE opsonization of that lipid nanoparticle in the circulation, and it gets rapid distribution to the liver through the hepatic artery. Once it gets to the cell membrane, it looks for the LDL receptor. That's the way that's going to enter the cell. And once it's inside the cell, basically what happens is the breakdown of that lipid nanoparticle and the release of the Cas9 mRNA and the TTR-specific sgRNA into the cytoplasm. Once that occurs, there's translation of the Cas9 mRNA forming the endonuclease Cas9, and then ultimately that binds with the TTR-specific sgRNA where it forms that CRISPR, which is basically like palindromic repeats, ribonucleoprotein with that single guided RNA. That makes the cell basically try to introduce this CRISPR sgRNA ribonucleoprotein, import it into the nucleus, and once it's in the nucleus, what it does, it looks for the complementary DNA and it binds near this PAM. Once it does that, it basically it induces the unwinding of the chromosome, and that then binds the DNA at that TTR gene, including targeted DNA cleavage, which is what we're trying to look to get out that TTR portion. And then basically once we remove that, the endogenous DNA repair basically results in the introduction of these indels, which is variants that have no significance to prevent that production of the functional TTR protein. So that's why we're very excited, because this seems to be something that's safe, now looked at in a phase 2 trial, now a little more patients, 12 patients, to see exactly what they would accomplish. They followed these patients about 4 to 6 months. Same thing as a phase 1. It showed that it decreases the TTR in the serum very robustly, 90% range. And what we're most excited is that soon here at CCF, we're going to start a phase 3 study looking at this agent as well in ATTR cardiomyopathy. And so, with this, I think the important thing is to know there's therapies available beyond tafamidis. Usually when we see these patients that have a hereditary cardiomyopathy and they have polyneuropathy as well, sometimes we choose to do combination therapy. The financial toxicity can be an issue, but we work in conjunction with our neurology colleagues that help us tremendously to be able to get the patient sometimes on one agent or two agents, depending on how they're doing. So with that, I'll leave you with Dr. Hannah.
You've heard about stabilizer therapy. You've heard about reducing production at the hepatocyte level. I think the holy grail that we've all wanted to try to do is remove amyloid fibrils from the organs, actively remove them. And we thought for a long time this was kind of pie in the sky. So this is, a typical echo we look at. This is a 72-year-old African-American female with the hereditary ATTR variant. And all of you take care of these patients who have markedly increased wall thickness. They have NT-pros in the 2,000 to 3,000 range. And you can give them tafamidis. You can even potentially, when it gets FDA approved, a silencer. But ultimately, they're still left with very substantial stiffness of the myocardium, dysfunction, etc. So the thought of the holy grail of removing amyloid fibrils we were never really enthusiastic about that because these are very insoluble fibrils that are extracellular and very resistant to degradation. Now, what was really interesting, in June of 2023, the group at the National Amyloidosis Center in London wrote a letter to the editor, to the New England, about 3 male patients in their very large ATTR cardiomyopathy practice, ages 68, 82, and 76, where the ATTR cardiomyopathy resolved spontaneously with reversion to near normal cardiac structure and function. In each of these patients, their symptoms nearly went away, and they didn't receive any treatments. So when they did a deeper dive into these patients, this, for example, is patient number 1, and you can see at baseline in the cardiac MRI, you see increased wall thickness, the ECV was elevated, and at 3 years, they repeated the MRI when they noted the symptoms resolved, and there was near resolution of all the wall thickness, and the ECV went to normal. And you can look at the baseline DPD scintigraphy where there was diffuse uptake, which essentially vanished. What they noted in all 3 patients was a high titer circulating polyclonal IgG antibody to human ATTR amyloid in each of their samples. And these antibodies bound specifically to ATTR amyloid deposits in tissue sections from mice and humans. And they looked at their many hundreds of other patients that they had and checked their blood because they had bank samples and repeated their blood and did not find these such antibodies. This is an example of patient 1. There's a murine specimen with TTR amyloid deposits. You can see where the Congo red staining is. This is TTR. And the serum from patient number 1, when applied, you can see is staining where the TTR is. And a control patient with ATTR cardiac amyloid who did not have these antibodies did not stain. So somehow this patient developed, their own immune system developed antibodies against TTR. And actually, patient 3, they did an endomyocardial biopsy, and they found that there was a macrophage in a giant cell. In the middle panel there, you see that, and in the lower panel, it's engulfing the amyloid fibril. And when they did mass spectrometry, you could see IgG complement in TTR. So again, there's some kind of very rare immune response that occurred in these patients that essentially reversed their disease. So there's been a big move to develop monoclonal antibodies to try to reverse amyloid deposits. And right now there's 3 that are in development. NNC6019, which used to be called PRX004, is a monoclonal anti-TTR antibody that is currently in a phase 2 cardiac trial, and they're likely going to plan a phase 3 sometime next year. We're currently not a part of that study, but the other 2 antibodies, which I'll go in a little more detail, we're going to be part of those studies. NI-006 and AT02. So NI-006 is a humanized IgG monoclonal anti-TTR antibody that is infused monthly. In this phase 1 study of 40 patients, they randomized 2-to-1 monthly infusions of NI-006 for 4 months or placebo for 4 months. And then everybody, all 40 patients, went into an 8-month open label infusion program. These patients were around 70 years of age. 39 out of 40 were male. The majority were wild type. Median NT-proBNP was around 1,800. None of the patients developed serious adverse reactions to the infusions. There were no anti-drug antibodies that were shown. And when you look at the effects on the MRI, let me take you through this slide. On the left here, you see the baseline extracellular volume on the MRI. ECV correlates with how much amyloid you have. So most patients with amyloid have an ECV over 40. Normal is about 32. So the ECV there, you can see a placebo, and the patients who are getting drug are substantially elevated. And you can see at 4 months in the patients treated at 10 mg per kg or greater, you already see an ECV reduction over 10% in some of these patients. And at 12 months, you see ECV reductions 15% and more. So that's really unheard of in amyloid. So that's very intriguing and encouraging kind of pilot data to suggest maybe there's some ability to reverse the condition. So this is patient number 3, 6-year-old man who was from the get-go randomized to NI-006, 30 mg per kg, so at one of the higher doses. You can see the ECV started at 60%. At 4 months, it went down to 48%. And at 12 months, it went down to 42%. This doesn't happen in amyloid. The opposite happens, or at the very least, it stays the same. So this is dramatic. And then the 62-year-old patient below that started at 57%. At 4 months of placebo, he obviously didn't change, 55%. And then when he was randomized for 8 months to these monthly infusions, it went down to 40%. Again, very encouraging, intriguing data. And the same thing goes with the scintigraphy, the technetium, just to show you a couple examples here. The patient at the top, 75-year-old male, you can see at baseline very diffuse, intense cardiac uptake, and then at 4 months and less, and at 12 months, almost disappearance. And then the patient below, again, initially placebo for 4 months, and then after 8 months of infusions, substantially decreased uptake. So this is a nice signal. Safety was established. So now there is a phase 3 multinational double-blind placebo-controlled trial called the Depleter trial. They changed the antibody name to Alexion 2220. And these can enroll patients with NT-pros over 2,000, so they want to enrich the population with a little sicker patients. But we will be a center here at the clinic, and we probably start in the next 2 to 3 months. The other antibody is called AT02. That gentleman right there is Jonathan Wall from Knoxville, Tennessee. He developed this monoclonal antibody that recognizes all amyloid fibrils. So this is very exciting. AL, ATTR, AA, any type of amyloid. What it has is it has a peptide there you can see circled, and that peptide recognizes the highly electronegative surfaces on amyloid-bound heparan sulfates on the fibrils. And it for whatever reason only binds amyloid fibrils. So it binds there, and then ultimately what it does, just like the other antibody described, it creates an immune macrophage-mediated clearance. So this current antibody is being studied in the phase 1b and then about to start a phase 2 OLE in 5 centers Australia, and there are going to be 5 centers United States. We'll be one of them. We're screening our first patient today, and then a center in London. These are monthly infusions up to 2 years. And what they're looking at, there's 7 MRIs in this study. They're looking at change of LV mass and ECV, and obviously looking for safety, infusion-related reactions, et cetera. So I think this is incredibly exciting, not only because it could potentially be a treatment for ATTR, but it can be a treatment for AL, it can be treatment for AA, some of these other rare types that have no treatment. So in summary, the monoclonal antibody trials with these 3 agents, you can see the NI-006, now Alexion 2220, is about to start a phase 3, the phase 2 for AT02, And then, of course, we'll be anxious to see what the phase 2 results for the NNCO19 is. I think ultimately speaking, unfortunately, we do try to diagnose these people early, but all of us see patients at the right side of the screen where they're more advanced. And this is where I think this antibody therapy could be very useful if it shows efficacious. The unanswered questions for ATTR, before I turn it to our hematology colleague to talk about AL, is what will treat the disease better, silencers or stabilizers? What about combination therapy? If you're silencing the level, do you still need to stabilize? And will we actually be successful at reversing TTR amyloid deposits in the heart? And what combinations will be best and affordable? So with that, I will turn it over to Jack Khoury, who's one of our hematologists specialized in multiple myeloma and AL amyloidosis, to give us an overview of treatment.
Okay, so the main treatment for AL amyloid aims at shutting off the source of the amyloidogenic light chain in AL amyloidosis. So a lot of the treatments that we use are borrowed from the multiple myeloma armamentarium, since that's the same cell that causes the problem here. And currently, there's a lot of drugs that we can use. As you can see, a lot of them target the plasma cell. And the main aim here is to reduce the production of the actual amyloidogenic light chain. The new wave of clinical trials, as Maz discussed for ATTR, is actually also aiming at targeting the actual fibril that's deposited in the heart and the other organs in hopes to improve the organ function that many patients are left with, organ dysfunction and leading to poor survival. So the survival of AL has improved over time, regardless of the treatment that people got. And this is basically due to the fact that more patients are diagnosed early and the treatments are actually improving with time. We all know that it's really, really important to get people to a deep hematologic response, basically dropping the light chain to a very low level, a very deep hematologic level, and rapidly. So we know that patients who achieve a very deep hematologic response, basically what we call a VGPR, so very good partial response or better, these are the patients that do best. So it's really important to drop that light chain, and VGPR is a difference of free light chains of less than 40. So patients who achieve that or better are the patients that fare best. And this is basically the aim of a lot of the things that we do in AL, to rapidly reduce that light chain. This diagram shows the evolution of the treatment of AL. So back in the 90s and the early 2000s, we mostly aimed at using alkylating agents. So melphalan, which is a chemotherapy drug that was used commonly in myeloma in combination with steroids, so prednisone or dexamethasone. And then studies on myeloablative dosing of melphalan, so high doses of the same chemotherapy drug in combination with a stem cell transplant, was implemented in the early 90s and early 2000s in these patients. And this is more for eligible patients. So this treatment is very toxic. And so the selection of patients was a problem because there was increased mortality with this treatment, which led to the development of more tolerable treatments. And the mainstay for a long time, since at least the 2010s, was Cybord-D, which is a combination of cyclophosphamide, bortezomib, and dexamethasone. And then more recently, in 2021, the standard of care changed with the addition of the anti-CD38 monoclonal antibody daratumumab to Cybord-D, which constitutes the main standard of care. The way daratumumab works is it targets this CD38 protein on the surface of the plasma cell. CD38 is very important for the survival of the plasma cell, and so when the drug binds to it, it tags it for destruction by NK cells, phagocytes, and complement fixation, which leads to killing of the actual plasma cell. Now, the main study that set the standard of care for amyloidosis, for AL amyloid, is the Andromeda study that was published in NEJM in 2021, which led to the FDA approval of the combination of daratumumab with the standard of care at the time, which was bortezomib, cyclophosphamide, and dexamethasone. The study was a randomized phase 3 study of about 400 patients that randomized patients in a one-to-one fashion between VCD, which was the standard, or VCD with daratumumab. The initial cycles were, the initial treatment consisted of 6 cycles of treatment, and then patients continued on daratumumab maintenance if they were in the daratumumab arm, or just observation if they did not receive daratumumab. Patients who were excluded in this study were patients who were sicker, mostly advanced cardiac patients, so stage 3A stage 3B patients who had an NT-proBNP of 8,500 or higher. So a lot of these sick people were excluded. The primary endpoint was hematologic complete response, which is basically normalization of the involved light chain, either kappa or lambda, and the ratio of kappa and lambda. These are the results of the Andromeda study. So the primary endpoint, which is complete response, was definitely better with the addition of daratumumab. So more than half of the patients achieved the complete response versus only barely 20% of the patients with the standard of care at the time. Looking at deeper levels of light chains, which is better for patient survival, again, same thing. 70% of the patients achieved an involved free light chain level of less than 20, which is a very deep response. And the difference of free light chains of less than 10 milligrams per liter was also seen in more patients who received daratumumab. Another endpoint that was looked at in this study was the major organ deterioration progression-free survival, which was a secondary endpoint, which basically looked at patients who had no deterioration in their cardiac or renal status, so patients who did not need further intervention for their cardiac disease, so LVAD, heart transplant, and such, and patients who did not have renal deterioration, so patients who did not end up on dialysis. And they looked at those patients separately, and again, we did see improvement with the addition of daratumumab. The 2-year follow-up of this study showed that the responses continued to deepen over time, so more patients achieved CR, complete response, with time at 2 years, versus with the standard of care, the number was still the same. So daratumumab is definitely something that improved the standard of care that we had at the time. And this study basically led to the approval of this combination, the quadruplet therapy for patients with AL amyloid. Looking at response rates, so cardiac response rates also were better at 6 months and 18 months with the addition of daratumumab. So 50% or more of the patients at 18 months had recovered their cardiac dysfunction versus about 20%. So there was more than doubling of the response here. Same thing for renal. At 6 months and 18 months, more than 50% of the patients achieved organ response versus 20% for the standard of care. Quality of life also improved with the addition of daratumumab, looking at 2 scores here that we use in AL, so QLQ and C30, looking at global health status and fatigue. There's definitely improvement with the addition of daratumumab with good tolerability. The unanswered questions from that study is basically for patients who have worse cardiac disease, so stage 3B patients with the NT-proBNP above 8,500. Patients who had advanced renal disease on dialysis were not included either. And again, so complete responses were seen in more than 50% of the patients, but there's still about 45% of the patients who did not really achieve that CR. So, we still need more, more work in that area. This is a treatment algorithm for how we treat AL amyloidosis currently. So the first line is with daratumumab, bortezomib, cyclophosphamide, and dexamethasone. We need to achieve at least a PR with this. If there is no PR, if the patient is eligible, we move on to a stem cell transplant. If not, then we can follow the algorithm for relapse disease. If someone achieved a CR or a very good partial remission, then we can just continue with the Andromeda protocol. Now, let's say the patient did not really achieve a partial response. This is when, the treatment is really, there's no standard of care and it's basically dependent on the hematologist. But a lot of the treatments that we used are, again, borrowed from multiple myeloma. A drug that's very promising that we have published on is venetoclax, which is a BCL2 inhibitor. BCL2 is an anti-apoptotic protein, and if you block it, you can potentially help kill the plasma cell. And it's been used for people with translocation 1114, which is a chromosomal translocation that we see commonly in amyloid in about 50% of the patients. And this drug has really shown a lot of promise in this arena. Now, moving on from targeting the plasma cell, like Maz was talking about in ATTR, the new wave of therapies is also aiming at clearing the amyloid fibrils in hopes to improve organ dysfunction in our patients. Again, 50% of the patients are left with organ dysfunction, and so it's an unmet need in this situation. So two antibodies that we're looking at in AL amyloid, CAEL-101 and bertamimab, and they both target different epitopes, cryptic epitopes on the surface of the misfolded light chain, and they're both in clinical trials right now. The bertamimab clinical trial, so the bertamimab drug was tested in a large phase 3 study called the VITAL study. The study was not successful. It did not meet its primary endpoint. However, when they did post-hoc analyses on patients who were sicker, so Mayo stage 4 patients, and these are the patients with elevated troponins and elevated NT-proBNPs, there was a survival benefit in those patients at 9 months. So there was a signal for those patients. And currently the drug is being tested in a large phase 3 study that looks at patients with stage 4 amyloid only. So this study is only for stage 4 AL amyloid. We do have it open here at the clinic, and it randomizes patients to standard of care with bertamimab versus placebo. And the primary endpoint is all-cause mortality, and there's a bunch of secondary endpoints, including 6-minute walk test. The other anti-amyloid fibril antibody is CAEL-101, which targets a different cryptic epitope on the misfolded light chain. We were involved in the testing of this drug here at the clinic, and we did have the phase 2 here open that included 2 parts, Part A and Part B, which involved giving the drug initially at 4 weekly doses with standard of care chemotherapy, and then moving on to maintenance with biweekly dosing. The second part included daratumumab after the approval of daratumumab for AL amyloid. If you look at the cardiac responses, so blue and green is either stable or resolved. A lot of patients achieved at least stable organ response or better. And even after cessation of we did see the same thing. So more patients achieved stable and or resolved or response in the cardiac response. So this is very promising, and there's currently 2 phase 3 studies that have fully accrued looking at this drug, and we're awaiting the read on those studies. Thanks.
Thank you, Jack. We're very spoiled here. We have about 6 extremely talented experts here in AL amyloidosis and myeloma. So they often see our patients within a week because these patients, unlike TTR, they really need to be treated very quickly. So I hope that this overview gave hope to the field and gave hope to patients out there who are listening that, we're doing our best to finish these clinical trials and expand treatments. I think with that, we'll open the floor to questions.
It seems to be critical for many of these therapies to identify these patients early. ECHO obviously is a late player there. When the walls are thick, probably these patients are maybe too advanced. I mean, is there anything earlier that we can actually be looking for in these patients?
I'll talk about AL. I'll have one of my colleagues talk about ATTR. So for AL, when I started here and patients presented with heart failure, they'd often be not alive within a year. And then bortezomib came along, and now daratumumab. And I have patients who've presented with advanced disease who are living for 3, 4, 5 years. So, and obviously we have heart transplant if we need it. But at the end of the day, I think that's really good news for the patients. But you're right, we need to diagnose them early. I think understanding the extracardiac manifestations for cardiologists to recognize that, and then to look at the whole picture for AL, try to diagnose them earlier and prompt every time. See, what we're seeing now, and while Jaber knows this very well, is patients are ordering PYP scans because they're just thinking TTR, and they're not ordering the appropriate lab testing to rule out AL. So that's happening, and that's why there's a delayed diagnosis. So I think just doing that, when you think about it, do that, and that'll help really. As far as ATTR, maybe I'll let Trey Martin answer that.
Yeah, so it's a very good question. I think as that slide showed that we're often, even in present day, even though we're diagnosing increasing numbers of particularly wild type TTR, that we're still catching them more in the NAC stage 2 and 3 when they come to their ultimate diagnosis. I think there is a lot of low-hanging fruit, and if you think about where most heart failure is cared for around the country, it's by general medicine inpatient docs and outpatient docs. So I think we have to do a better job of supporting them. I think potentially through the EHR and alerting tools that happen behind the scenes, but don't add to clinical burden for them, but take it out of their hands. That if you take a constellation of factors, including echocardiography, EKG, clinical history, things like carpal tunnel, and there's certainly things been published in terms of simple risk scoring. I think we can get to a place where we're doing a much better detection of things that are literally on fire, but they're unrecognized to people who are non-expert. So there's education, there's clinical alerting. I think those are the things that we can move very quickly to do a better job at this.
Manu?
As I've been impressed by how good NT-BNP is a biomarker in this situation for outcome. Is the NT-BNP a marker for just stiffness? Is it the interaction of the renal failure and the heart failure all together causing that NT-BNP to be up? So is the prognostic ability of NT-BNP independent of heart function? Or you say disconnect between stage of heart failure and NT-BNP?
Yes. No, I'm just kidding. That's a complicated question. I think NT-proBNP does highly correlate with prognosis both in AL and in ATTR. The staging systems in ATTR, there's two of them. One is the National Amyloidosis Staging System, which basically looks at NT-pro and eGFR. And the cut point they use is very crude, but over 3,000 is more advanced, under 3,000 is less. And if your GFR is under 45, that's worse. And if the combination of a GFR under 45 and NT-pro over 3,000 is stage 3. And then the other one is the Mayo score, which relies on troponin and NT-pro. I do see a disconnect. I have a gentleman, this is an example. He's 69, retired physician. He's got an ECV of like high 50s, very substantial load on MRI. His NT-proBNP is 600, and he's NYHA1. So I don't know. I think it's obviously stiffness. I don't know if it's compression, a combination of the two. But I don't know. As far as I think it's very prognostic. Do you have any comments, Jack, about NT-proBNP more than we know? Okay. All right. Anybody have any comments for that question?
Yeah, I think you do see normalization of filling pressures, though, and persistent elevation, right? So it's not just a congestion issue.
Oh, yeah,
right?
Definitely not. Yeah.
One more thing is NT-proBNP is a marker of stretch as well as infiltration in these patients. And 2, whether they have AFib or not an AFib. And 3, if there is clot or no clot. So there are multiple factors that contribute to NT-proBNP. And I think the degree of adding each of these problems adds to the complexity of staging and complications as well. So the answer would be an overall mix of all.
Yeah, great point, Preeti, about the AFib. So for the clinical trials, for example, they'll say to be a candidate, you have to have an NT-pro of at least 600 or above, or over 1,000 in AFib. Because just when you go into AFib, even in HFpEF patients, it'll just go up regardless of the volume. But I think that, it's very rare to see once you've got them euvolemic and you put them on therapy, it's very rare to see reduction in NT-proBNP. And the fact that these antibody studies, the one that I showed you where it went from like 2,300 to 800 is really, really remarkable. Yeah.
Is in any of the studies that were done, silencers and stabilizers did they look specifically at reduction of arrhythmias? And I know that they don't have loop recorders and what have you, but has there patients who had atrial fibrillation, for example, did they look specifically at some reduction of arrhythmias with those treatments? Because this is going to shed some light now that we have treatment options. Before, we were giving up on those patients with amyloid, whether they have reduced LVEF or protracted AFib. We kind of put it. Now that we have active treatment therapy, we have to rethink our approach of how we treat those patients, whether we put ICDs or whether we send them for ablation and stuff like that.
Yeah, the only analysis I'm aware of is in the ATTR study. So Ron Wittelis, who's one of the authors, presented an abstract last year at the International Society of Amyloidosis looking at the incidence of AFib and tafamidis versus the placebo arm, and I don't remember the exact details, but there was less. But I think that's a huge thing because all of these patients end up getting AFib and they do worse. So if these therapies reduce the incidence of AFib, I think that's, something that needs to be looked at in the Apollo trial, that needs to be looked at in the ATTRibute trial with acoramidis. I think those are all very important points. And you are seeing a lot of these patients, obviously. Thanks, everybody.